Very good morning to the moderators on the dais and friends in the audience. So, my job the next few minutes is to talk to you all about the iris clip lens or the retrocapillary iris fixation IOLs. Now, why was it that this evolved and what is it had to offer when there was an inadequate capsular support? The ACIOs were in a time when we were still acquiring our surgical progress, and probably on hindsight, if you look back, if our surgeries had been perfectly done, probably the ACIOs would have also a place in the armamentarium as a secondary IOL of choice. But the critical issue for an anterior chamber IOL is the sizing of the IOL, which is what is the defining factor, and because it failed was because it was closer to the endothelium. The iris clip lenses came as a huge advantage. One, surgically it is very easy to learn, and it is also placed behind the iris and well away from the endothelium. Only thing, you need to have an iris support. So suppose it's a case of an essential iris atrophy, or it's a case of an aniridia, or it's a neovascularization on the iris, or it's a case of uveitis. These are clear-cut situations when you would not choose an iris clip IO as a secondary capsular support, eyes without a capsular support. Of course, SFIO have their own standing today and with a variety of lenses which have come across, but then it definitely needs a little more of a learning curve. So the procedure for an iris clip lens is fixing the lens to the back of the iris and requires sufficient iris tissue. The lens, it comes at an optic diameter of 5 mm, overall length of 8.5 mm, and it has oval haptics, and you can see it has pincers at the end of the haptic, which is how it grips the iris. And the A constant we need to remember is 117.2, and different people in markets come with slightly differing but nearly the same IOL part. And how it evolved, it came from a plano-convex to biconvex to concavo-convex lenses as they offer. But what we need to remember, supposing the patient was for a 3-piece IOL in the bag, assuming it was 118.4, and then he has a surgical complication and you want to place an iris clip IOL, it's 117.2. So you need to subtract that 1.2 and then subtract it. Supposing the IOL bar was to be 24, it needs to be 22.8. So that is how you would have to calculate your IOL bar. The instrumentation is so basic and simple. You just need forceps to stabilize the IOL as you are inserting it. You need to make your paracentesis with your sideboard plates, and then you need to just have one simple dialing hook to enclavate the iris, or even an ordinary syringe with a cannula would do. Now, as far as the basic surgery is concerned, essentially you make your conjunctival peritomy, and supposing it's a case of a situation like this as a very subluxated cataract where the primary plan of action is then it's best to make a scleral tunnel and not enlarge the corneal incision, because you need to, from a 2.4 you would have to enlarge it to insert a 5 mm optic of the IOL. You would not make a superior tunnel if you think this patient might need a glaucoma surgery later. You should make a thick enough flap, but not too thick that you have a premature entry, or not too thin that you have a buttonholing. Supposing you want to do a temporal corneal incision, then what you would need to do is, if you have already made a limbal incision, you could make your side cuts and then do it, or you could plan a temporal clear corneal in a different plane. Now, as far as anterior vitrectomy is concerned, before you are going to plant your IOL, you need to do a good anterior vitrectomy. You inject tricot to see whether there is no vitreous strands which are there, and definitely top it up with a YAG PI. Although, if you have done a good vitrectomy, there are some who would question what is the role of a YAG PI. You need to constrict the pupil with pilocarpine, and after you have placed your, as I am going to show you here, you make your side ports at 3 o'clock and 9 o'clock if it's a superior incision, if it's a temporal incision, 12 o'clock and 6 o'clock. And after you make your side port incision, what you do is, through the main port, you with the enclavation forceps, you hold your optic and then go through the side port and just a dialer, push the iris so that it is caught by the pincers of the haptic behind the IOL, and stabilize the IOL and repeat the same process, inject viscoelastic so that you have created space, then go in and stabilize the optic and go through the other side port and then just nudging the iris tissue so that, and hold the optic close to the iris from posteriorly. Now what you need to be careful is you use a symmetric amount of iris should have been tucked in both, and that pressure, counter pressure, you will learn by experience. And if too little is got, you might get an asymmetric like an oval pupil kind of appearance. You need to do an adequate visco wash, which is most important. And sometimes you could even, if it's a superior tunnel, you can go to the side port and nudge the iris out so that you are able to pull it out and do a PI. Post-operatively, enough anti-inflammatory is needed. If the iris tissue is inadequate, as it was in this case, the primary surgeon had made a large PI. As you can see, it comes up. So it is still possible, because on either side there is enough iris tissue. You could go ahead and insert a lens and clip it. You can even obliquely place the iris clip lens. It's not necessary it's only horizontal or vertical. As long as there's enough iris tissue, you could enclavate it. This is a very large eye with, large pupil, a chromatic mydriasis was there. There is always a chance, ease for you to do a pupilloplasty, complete your pupilloplasty, and then you could just nudging an iris clip lens, and in matter of seconds, these are all practically unedited videos. You could just place your, once you have downsized the pupil size, you could go ahead and place your iris clip lens and enclavate it, ensuring it is symmetrically positioned. And this is how the eye looked following the surgery. Now this was a completely messed up pseudo-phakic bullous keratopathy, and all you have to do is scrape the entire unhealthy epithelium, and after you have debrided it, you can, I wish I could fast forward it, you could place your iris clip lens, and once you place the iris clip lens, you could do your DSEC procedure and insert the DSEC clamp and then complete your case with great ease. Now what happens if the haptic disinclavates? Now if the haptic were to disinclavate, as is going to be shown to you, when you go back, you should ensure that the vitrectomy is done adequately if there is any issue there. And after doing the vitrectomy, you will myose your pupil and then hold the optics and stabilize it and re-enclavate it. But at the site of during re-enclavation, you should also find out what could have gone wrong. Is the haptic broken, or is the iris tissue torn in that area? Should you re-enclavate in the same place, or should you re-enclavate somewhere else? Are some decisions to be taken. Now this was again another case where it had disinclavation is done. Sometimes when you are re-enclavating, you realize that the other side is also not enclavated well. So you should disinclavate and re-enclavate. For that, you need to just hold the optic of the iris clip and push it posteriorly, and with the spatula from the other side port, just lift up the tissue. Sometimes you can easily do it from the anterior approach, but sometimes you may have to nudge the iris out by going behind the IOL. So essentially, all these small tricks are hardly ever necessary once you've got the knack of doing the procedure. It can be done under topical anesthesia or a subtenon rarely. And definitely you get a deep anterior chamber, you are quite gentle with endothelium, there's no sizing issues, very short learning curve, and some minimal manipulation of the vitreous is all that is needed. Thank you very much.